Now I think it's live.
Okay. Uh, okay. Yes, we can start.
Yeah. So, good afternoon, everyone, and a warm welcome to all the dignitaries present here. I'm Srevshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat, and the focus of today's session is lessons from expert neonatal cardiac emergency. So let's begin today's session, for which I would like to invite Dr. Kunal Ahya sir to take over. Over to you, sir. You can proceed now.
Thank you so much, Shreyashi. It is a great pleasure to have Dr. Bhavik with us. We have talked over phone many times while we were referring our newborns to UN Mehta Hospital. So it is a great pleasure to hear from him live. So this is our Neonatal Pathshala series, which we conduct on every Wednesday between 3 to 4 p.m. And even now we are going to start our neonatal nursing series, neo nursing series of Pathshala in Gujarati for the neonatal nurses also. So I request all the units to please join all your nursing staff so that we can have more and more participants and everyone can benefit from it. It will be in the local language. For today's session, I would request now Dr. Vishal Goyal, who is our project in charge, for further coordination. Thank you, Vishal.
Thank you, Kunal. Yeah, so today's topic is the neonatal cardiac emergency, and I think each and every pediatrician, including neonatologists, are facing the cardiac emergency. I think many times, not only the NICU but also in the OPD. And for that, I would like to invite our renowned faculty from India, Dr. Bhavik Champaneri, and he's a DM pediatric cardiology, and currently he's working as an associate professor leading the department of the pediatric cardiology at UN Mehta Institute, which is one of the renowned centers from India. I think he has more than 10 years experience of the pediatric cardiology, and this era, I think he operated more than 5,000 transcatheter pediatric cardiac intervention, including complex procedures. If I talk about the neonatology, I think he is also doing a transcatheter closure of the PDA, which is one of the difficult tasks, to close the PDA in the tiny preterm, and he is much experienced on that one. So I welcome Dr. Bhavik, and you can now share your screen and start your session.
Yeah. Thank you, Dr. Vishal and Dr. Kunal, for your kind words. I'll start with my presentation. So, yeah, I've started. Are you able to see it?
Yes.
Yes, yes.
Yeah. Yes. So, good afternoon, everyone. It's my pleasure to be on this platform and sharing my knowledge with you all. So today I'm going to talk about cardiac emergencies in neonates. So first of all, why it is important? We should know that this is an important slide published in 2005, uh, which is talking about a neonatal mortality. So as the neonatal mortality is on a higher side, this purple color which you are seeing is a causes of congenital malformation as a cause of neonatal mortality, and most common causes here stands are sepsis, asphyxia, and preterm delivery. But as you can see, the neonatal mortality is coming down here, and as you see, reach the number which is less than 15 per 1,000 live births. Next, second most common cause of neonatal mortality is due to congenital malformations. That includes all congenital malformations. But when we are talking about congenital malformation, congenital heart disease accounts for 25% of patients with 25% of patients with congenital malformations. Congenital heart disease is that common in overall congenital malformation patients. And when we are talking about congenital heart disease, out of that, because we are talking about cardiac emergencies in neonate, out of that, all congenital heart disease in neonates, 25% of those patients has critical congenital heart disease. So it is important to know uh, that spectrum of disease or that spectrum of patients, if that is not treated in timely manner, we are losing those patients, and that is adding up on our neonatal mortality rate. And what is defined as critical congenital heart disease? The congenital heart disease which has to be treated within 1 month of life. If it is not being treated, we may lose this patient, or we may lose the window of opportunity where child can serve to the community in a normal manner, and it will be help in a for it will be important from a public health perspective. So that is the reason, when the neonatal mortality rate is coming down, the death because of congenital heart disease is of great importance when we are talking about improving the perinatal care. So this slide shows the importance that now congenital malformations and in that congenital heart disease is of great importance when we are talking about a neonatal mortality rate. Coming to congenital heart disease, its birth prevalence. Overall, the birth prevalence of congenital heart disease is around 8 to 12 per 1,000 live births. So, with that number, if we are counting the children which are born in India with congenital heart disease, will come to 2,40,000 uh, children every year. But out of this birth prevalence, around 25% of patients have critical congenital heart disease. So that comes to the number of 1.5 to 1.7 per 1,000 live births. This number of children are born for every 1,000 live births, and if we calculate the number out of that, it will come to 50,000 neonates are being born, or children are being born every year with critical congenital heart disease. And if we look at the data, overall the capacity of India to treat, or rather than capacity, the number of children being treated for critical heart disease within 1 month of life, as per the Pediatric Cardiac Society of India, that number is somewhere around 10,000 to 15,000 children a year. So what is happening to those patients who are being the remaining 35 to 40,000 neonates every year are very likely not being diagnosed or not being treated in timely manner, and we are losing on this patient, which is adding to our neonatal mortality rate. So the importance of this talk will be to identify these kids and to refer in a timely manner so that they reach to the place where the treatment is being provided, and so that we can salvage these babies as much as possible and give them near normal life. It's important that out of this all critical congenital heart disease, majority, I would say 60 to 70% of this critical congenital heart disease are such that they can be converted into a normal heart. What we mean by normal heart is called a two ventricle physiology. Like a four chamber heart can be created. Other is a single ventricle physiology where you are not able to make it into a two ventricle heart repair. But out of this critical congenital heart disease patient, nearly 60 to 70% of children are having a heart disease which can be corrected and make this heart into a normal two ventricular heart. It is important because if you are able to make a corrective surgery in such patients, their life expectancy and their quality and their the capability of these children are very much like a normal human being. So here we are not just reducing the neonatal mortality, but we are overall impacting the public health in the term of saving a critical congenital heart disease. So first of all, what are the presentations of neonatal cardiac emergencies? First, any heart disease with neonate, most common presentation is hypoxia or cyanosis. Second common presentation of critical congenital heart disease in neonate is heart failure, or you can say cardiogenic shock. Other presentation can be arrhythmias, a neonate which comes with us with arrhythmia, and because of that he is going into heart failure or shock, and just detection of murmur, just detection of murmur. So identification of murmur in neonate also, it's possible that this child can have a critical congenital heart disease. If it is not treated in timely manner, we can lose on these patients. So coming to the classification of critical congenital heart disease in neonate, most common is a duct dependent systemic circulation. What do you mean by duct dependent systemic circulation? Means the cardiac output or a cardiac output or a blood supply to the lower part of the body distal to the ductus arteriosus is dependent on patency of ductus arteriosus. So what happens if that ductus arteriosus is closed or getting constricted? The blood flow to the part distal to the ductus arteriosus, that means the descending thoracic aorta. So all abdominal organs, lower limb, like kidney, liver, and the supply to the lower limb is getting hampered. That will give rise to your renal failure, liver failure, and cardiogenic shock because of lack of blood supply to the lower part of the body. Other important classification which comes into a classification of critical congenital heart disease include coarctation of aorta, aortic valve stenosis, congenital AV valve regurgitations, that means severe tricuspid regurgitation, which is seen in Epstein's anomaly, or severe mitral regurgitation, which is seen in various congenital mitral valve pathologies. Myocardial dysfunction, as we are seeing in sort of genetic cardiomyopathy or viral myocarditis. Various rhythm disorders. These are the various presentations, various diseases which presents with heart failure and shock. So these are the various diseases where this child will present with heart failure and shock. And when we are talking about a shock, it's a cardiogenic shock where we have a poor cardiac perfusion, poor perfusion of the limbs, the abdominal organs, the brain, and child may have because of that various presentations like hypoxic ischemic encephalopathy, liver failure, renal failure, total absence of urine output. Other group of critical congenital heart disease are duct-dependent pulmonary circulation. So again, here it's important to understand here ductus arteriosus is supplying blood to the lungs. In duct-dependent systemic circulation, ductus arteriosus is supplying blood to the abdominal organs or a descending thoracic aorta and rest of the body except the brain. So here, once the blood supply to the lung is getting hampered, what will happen is a reduced pulmonary blood flow. Reduced pulmonary blood flow will give rise to development of cyanosis. Various other congenital heart disease which may present with severe cyanosis include deep or transposition of great arteries and obstructed total anomalous pulmonary venous connection. So these are the various congenital heart disease which present with cyanosis or hypoxia. And these are the various congenital heart disease which may present with heart failure and shock. So coming to the cyanotic lesions, duct-dependent pulmonary circulation, where the blood flow to the lungs is dependent on ductus arteriosus, and various examples of this congenital heart disease include pulmonary atresia with intact ventricular septum, that means without the presence of ventricular septal defect. Pulmonary atresia with VSD, ventricular septal defect, that is also called a sort of tetralogy of Fallot with pulmonary atresia. Severe form of tetralogy of Fallot where the antegrade flow into pulmonary artery is so less that this patient gets cyanosis when ductus arteriosus starts constricting. Critical pulmonary stenosis where the flow from right ventricle to pulmonary artery is so low that the lung circulation is dependent on ductus arteriosus, and once that ductus closes, this patient starts developing cyanosis. Epstein's anomaly, which comes in of tricuspid valve, where there is a severe tricuspid regurgitation. And because of that severe tricuspid regurgitation in neonates, at the same time, higher pulmonary vascular resistance in these neonates. So the pulmonary vascular resistance in this patient is so high that this tricuspid valve, because the tricuspid valve is abnormal, RV is not able to pump the blood from RV into PA because the pressure is high, and it is pumping the blood from RV to RA because that is a low pressure chamber. So it will give rise to a physiology which is called sort of functional pulmonary atresia. And in this patient, they may present with severe cyanosis. What do you mean by functional pulmonary atresia? That means the pulmonary valve is well developed, but the pulmonary vascular resistance is high. This patient are not maintaining saturation and they are ductus arteriosus dependent. And as soon as the pulmonary arterial pressure and pulmonary vascular resistance reduces, the flow from right ventricle to pulmonary artery increases, and then they become the saturation improves, and then they are not ductus arteriosus dependent. So that is a classic bimodal presentation of Epstein's anomaly of tricuspid valve, where the saturation is very low in neonates. It improves gradually once the PVR is improved, and at later stage of life, when the regurgitation increases significantly, this patient may have uh, again development of cyanosis because of shunting of blood from atrial septal defect. So when we are talking about duct dependent pulmonary circulation, it is not just a single picture, it's a different shades of gray. In the darkest shades of gray, that's a black color, the congenital heart disease with pulmonary atresia comes in the darkest form of duct dependent pulmonary circulation. And when there is a pulmonary atresia, they are absolutely duct dependent. As soon as the duct closes, there is a dramatic presentation, and they present with deep cyanosis because of ductal closure and reduced pulmonary blood flow. And the lighter variety, lighter shades of gray are the congenital diseases where there is pulmonary stenosis. So when there is pulmonary stenosis, the antegrade flow into pulmonary artery from right ventricle, it is there. But depending on the severity of the stenosis, they may be dependent on ductus arteriosus or they may not be dependent on ductus arteriosus. So there is a relative ductus arteriosus dependence, and as the ductus arteriosus closes, the varying degree of cyanosis may appear depending on the severity of pulmonary stenosis. So these are the various illustrations of pulmonary atresia which are duct-dependent pulmonary circulation. This is a normal heart. In this heart, you can see there is a large ventricular septal defect and the pulmonary artery is atretic. So what is happening to these lungs? The pulmonary arterial blood flow is dependent on the ductus arteriosus here. This ductus arteriosus is patent. Blood will flow from aorta to pulmonary artery, and that blood will go into the lungs, get saturated, and that is how the saturation will improve. But what will happen if this ductus arteriosus is closed? Ductus arteriosus gets closed, the pulmonary blood flow gets hampered, and this patient gets severe cyanosis. This is another example of duct-dependent pulmonary circulation where there is no ventricular septal defect and there is a the pulmonary arteries or main pulmonary artery is atretic. So again, ductus arteriosus dependent pulmonary circulation. In addition, what is important here? The blood from RA, because there is no outflow or egress to the right ventricle, RA, it gets shunted to the LA, and adequacy of atrial septal defect in this patient is very important, because if the atrial septal defect is restrictive, the RA pressure will remain high because from RA blood has to shunt to left atrium, and RA pressure will remain high and patient may go into right heart failure in addition to deep cyanosis because of ductus arteriosus dependent pulmonary circulation. This is an example of transposition of great arteries where the aorta arises from right ventricle, pulmonary artery arises from left ventricle, and this is called a parallel circulation in a cardiology manner, like in cardiology, because the blood which is desaturated enters into right ventricle, that same desaturated blood is going into aorta, and blood which is highly saturated coming from lungs enter into left atrium, it goes to left ventricle, and then again it goes to pulmonary artery. So the blood which is in the systemic circuit is a deoxygenated blood, and in left-sided circuit, the pulmonary artery, the blood which is circulating is a highly oxygenated saturation. So in this patient, the saturation is dependent on the mixing of the blood, deoxygenated and oxygenated blood, and that mixing, the base location for mixing of this blood is at the level of atrial septum in the form of atrial septal defect. So when this patient have a good size atrial septal defect, the saturation of this patient may remain on a higher side and they may not become very blue and not become acidotic. But if the atrial septal defect is small, the mixing of blood between RA and LA does not happen, and these patients become highly blue and very cyanotic because of respiratory acidosis, and we may lose on this patient, and that is where the adequacy of atrial septal defect is important in patients with transposition of great arteries. These are various examples of total anomalous pulmonary venous connection. These two examples are cases where the presentation is very critical, and in a neonatal presentation, they present with cardiac emergency in the form of severe cyanosis. and respiratory distress syndrome with whiteout lung. This is an example of total anomalous pulmonary venous connection where all pulmonary veins join together and drain via ascending vertical vein into innominate vein. And this vertical vein is stenotic, giving rise to severe pulmonary venous hypertension because of obstruction. And that is why this patient have whiteout lung, what we see typically in patients with respiratory distress syndrome. This is the example where pulmonary vein draining through descending vertical vein into liver parenchyma or portal vein, and at the level of liver parenchyma, they gets obstructed, and that's why again this patient will develop severe pulmonary venous hypertension and severe pulmonary arterial hypertension. This is an example of unobstructed TAPVC, which is not a critical congenital heart disease, and usually these patients are not very blue, and they may require surgery maybe around 1.5 to 2 months of age. But these are the patients of obstructed TAPVC, which if not treated in timely manner, we may lose on this patient because of severe pulmonary venous hypertension and severe cyanosis. So these are various examples of duct-dependent systemic circulation. Again, here the systemic circulation or a cardiac output to the lower part of the body below the level of ductus arteriosus is dependent on ductus arteriosus, and these patients present with severe shock, cardiogenic shock, and heart failure. Various classic example include hypoplastic left heart syndrome, critical aortic stenosis, interrupted aortic arch, severe coarctation of aorta. So this again, like duct-dependent systemic circulation, again, it's a varying degree of presentation from darkest presentation which are classic presentation of hypoplastic left heart syndrome and interrupted aortic arch, where again it's completely dependent on ductus arteriosus, because once ductus arteriosus gets closed, there is a dramatic presentation, severely reduced blood flow to the lower part of the body, giving rise to shock, circulatory failure, renal failure, liver failure, and lighter shades of gray are aortic valve stenosis and coarctation of aorta, where there may be a relative dependence on ductus arteriosus, and once the ductus arteriosus closes, depending on the severity of valve stenosis or depending on the severity of coarctation, patient may either have features of circulatory failure and shock, or patient may remain asymptomatic for a certain period of time, and eventually it may present with heart failure symptoms. These are the classic example of absolute duct-dependent systemic circulation. This is an example of hypoplastic left heart syndrome where mitral valve, left ventricle, and aortic valve are hypoplastic, and the blood circulation is from pulmonary artery, right? RV, pulmonary artery. Through pulmonary artery, it will go retrogradely into ductus arteriosus, and it supplies the lower part of the body, and that is how the circulation is maintained. Once this ductus arteriosus gets occluded, the blood supply to the lower part of the body is affected, and patient may present with cardiogenic shock. This is another example of interrupted aortic arch, where the arch is getting interrupted at one point, and ductus arteriosus is supplying the remaining part of the descending thoracic aorta and abdominal aorta. And again, ductus arteriosus gets occluded. The blood supply to this part will get hampered, and patient may present with severe cardiogenic shock. So this is important to understand the evolution of coarctation of aorta. And why it's important? Because a neonate who may present at birth, you have seen the patient is completely asymptomatic, and you have discharged that patient. After 3-4 days, patient comes with cardiogenic shock, systemic shock, failure, renal failure, liver failure, and decrease or nil urine output. So this slide shows the importance of development of coarctation of aorta. As you can see here, this is pulmonary artery, this is aortic arch, this is the coarctation of aorta. Once the PDA or a ductus arteriosus is open, the blood is shunting from pulmonary artery into descending thoracic aorta, and that's why this patient is asymptomatic. And it is important to understand any neonate, even if it's a critical coarctation of aorta, immediately after birth, when the ductus arteriosus is patent, femoral arterial pulses will be palpable, and absent if the femoral arterial pulses are very much palpable, and there is no discrepancy in ascending the axillary artery or a radial artery and femoral arterial pulses, that does not rule out severe coarctation of aorta in neonates, because the ductus arteriosus is patent. What is important in this patients are the presentation with the cyanosis or a different. There will be a presence of differential cyanosis, because the upper part of the body is supplied by the oxygenated blood, lower part of the body is supplied by the ductus arteriosus. So the upper part means upper limb, right upper limb or a left upper limb saturation will be higher as compared to the lower limb saturation. That difference, presence of differential cyanosis in a neonate. One most common possibility is of persistent pulmonary hypertension of neonate, and the second most common reason for differential cyanosis is presence of coarctation of aorta, and that is why the role of oxygen saturation is important in detection of coarctation of aorta. So this patient is this is a slide where the baby is born with the coarctation of aorta. When ductus arteriosus start constricting, the coarctation of aorta gets manifested, and at one point of time, ductus arteriosus gets occluded, and there is a severe coarctation of aorta, and further compromise supply to the lower part of the body, giving rise to systemic shock and cardiogenic shock and heart failure. So this slide shows the importance of oximetry, SpO2 measurement in upper limb and lower limb, and detection of critical congenital heart disease like coarctation of aorta. So what is important now, when we have talked about ductus arteriosus dependent systemic as well as pulmonary circulation. So very important to have prostaglandin E1 infusion in such patient. PGE1 will cause the reopening of the ductus arteriosus, and maintenance of ductus arteriosus, giving rise to adequate supply to the lower part of the body in case of duct dependent systemic circulation, and adequate supply to the lungs in case of duct dependent pulmonary circulation. So prostaglandin is very much life saving in such critical congenital heart disease, and that is why it is important in neonatal setup to have at least 1 or 2 vials of prostaglandin infusion in your pharmacy store, so that in case you come up with such patient, you can save this patient just by starting one prostaglandin infusion. Once that ductus arteriosus is open, child is completely stable, and now you can transfer that baby to the tertiary cardiac center where the permanent care or a permanent solution is being offered. So this shows the importance of prostaglandin infusion, which is available in the name of alprostin, and which usually start in the dose of 0.04 to 0.2 microgram per kg per minute. And once the ductus arteriosus patency is established, we reduce it up to 0.01 or 0.005 microgram per kg per minute, depending on the ductus arteriosus size. Usually in duct dependent systemic circulation, we start with the higher dose because the systemic supply is very much dependent on ductus arteriosus, and we want a ductus arteriosus which is wide open. And in case of pulmonary duct dependent pulmonary circulation, we usually start with the lower dose because we want saturation to increase in a range where patient is safe. And our target saturation is around 80 to 85% and not more than 85%, because that will increase the pulmonary blood flow significantly and patient can go into increased pulmonary blood flow physiology. So our target saturation in duct dependent pulmonary circulation is somewhere around 80 to 85% and PO2 in the range of 45 to 50. We are happy with that because we want child to come out of critical stage and to reach in a stage where we can transfer to the tertiary cardiac center. Coming to the management of critical congenital heart disease, management can be in the form of transcatheter solution or a surgical solution. Various transcatheter solutions which are being offered in neonates with critical congenital heart disease are mentioned here. Transposition of great arteries with restrictive atrial septal defect, we do balloon atrial septostomy to salvage those patients so that they come out of severe cyanosis and severe acidosis, and to make them fit for next corrective surgery, which is arterial switch operation. Critical aortic valve stenosis, we do balloon aortic valvotomy so that we open the aortic valve by inflating the balloon at the level of aortic valve, and that is how we improve the flow across aortic valve. Critical pulmonary stenosis, where we balloon dilate the pulmonary wall and improve the pulmonary blood flow. In case of pulmonary atresia with intact ventricular septum, where the pulmonary atresia is not the long segment, but it's a short segment or a membranous pulmonary atresia. In such cases, what we can do is we can perforate the pulmonary wall or a membrane of pulmonary wall with the wire, and we balloon dilate it so that the pulmonary blood flow increases and patient comes out of cyanosis. For duct-dependent pulmonary circulation, transcatheter solution available is stenting of ductus arteriosus, where we are where so that we can switch off the prostaglandin infusion by putting a stent in ductus arteriosus and maintaining the patency by placement of the stent. So coming to surgical management can be in the form of complete repair or a palliative surgery. Complete repair is often being offered in case of arterial switch operation for transposition of great arteries. TAPVC, we can do a LA to common chamber of pulmonary vein. We open it and suture it so that pulmonary veins normally drain into LA. Coectation, in case we can do coectation repair, and in case of aortic arch hypoplasia or interrupted aortic arch, we do aortic arch repair. So you can see majority of congenital heart disease, complete repair is very much feasible, and after complete repair, the life expectancy of this patient is very much near normal. Various palliative surgeries can be in the form of BT shunt, where we provide an alternative supply of blood to pulmonary artery by putting a graft between aorta and pulmonary artery. And Norwood surgery, which is a very complex form of surgery, where the palliative surgery is being done for hypoplastic left heart syndrome. But hypoplastic left heart syndrome is in the darkest form of congenital heart disease, and often we do not entertain this disease because overall, despite being palliative surgeries, multiple staged surgeries, the outcome of such patients are not so good. I'll go through few case examples. So this is a first case where a full-term cesarean delivered male child weighing 2.8 kilo was admitted in NICU with respiratory distress syndrome, but there is no improvement in chest X-ray despite adequate management and adequate management in NICU. So this is an X-ray, completely white out lung, classic of hyaline membrane disease or respiratory distress syndrome. But despite adequate management, patient is not improving, and echo was done, which suggested obstructed infracardiac TAPVC. As you can see, this is a venous channel, descending vertical venous channel, which is going into liver parenchyma. And because it's an obstructed TAPVC, patient is having severe pulmonary venous hypertension, and that's why completely white out lung. And this is a illustration showing a intracardiac TAPVC. This patient was referred at third day of life. Patient immediately underwent TAPVC repair because patient was sick and there is no other way we can salvage this patient. Patient stayed in our ICU for 7 days, kept in step-down ICU and ward for 15 days, and was discharged on 15 days of life, has been on regular follow-up, and child has been doing well, and he will live normal life because it's a completely corrective surgery. This is another example. Full-term normal delivered male child weighing 3.3 kilo. Immediately after birth, he was detected to have severe cyanosis, and the SpO2 was in the range of 50 to 60%. Because of severe cyanosis, patient went into severe respiratory acidosis and sort of high lactates giving rise to lactic acidosis. Was referred here. This is an X-ray on presentation. It's a classic X-ray of egg on side appearance. What you are seeing, what you usually see in cases of transposition of great arteries. Child was detected to have transposition of great arteries, no ventricular septal defect, and foramen ovale was highly restrictive. So because of this foramen ovale, which is restrictive, the adequate mixing of blood does not happen between right atrium and left atrium, and that is the reason patient is highly blue and severely cyanotic. Patient was taken in cath lab. What we are being done here, you can see in this video, with balloon, we are tearing the atrial septum and creating a large or moderate size atrial septal defect. As you can see in this fluoroangio, we are inflating the balloon, keeping it in left atrium, and pulling it balloon down rapidly so that it tears the atrial septum. And that is how we create the atrial septal defect in neonates. In same patient, SpO2 improved from 50, 60% to 80%. Child became better, acidosis improved, child hemodynamically is stable. Uh, we waited for 5 to 6 days for stabilizing this patient. He underwent arterial switch operation at 7 days of life. Got discharged on 25 days of life and has been living normal life because it's a corrective surgery. Again, this is another case. 7 days female child who is delivered by cesarean section. Child went home on third day of life because child was completely stable. Again, on fourth or fifth day of life, child was admitted in NICU with severe respiratory distress. Child was intubated. On examination, femoral pulses are absent and there is no urine output since 24 hours as per the relatives. And in investigation, create is very high. SGPT and SGOT has gone up in 1,000, showing liver and renal failure as a sign of cardiogenic shock. Echo was done, which suggested severe biventricular dysfunction with critical coarctation of aorta and no PDA. If this PDA was open, this patient would not have behaved such bad, but PDA closed, which is a classic presentation of severe coarctation of aorta. Patient went into cardiogenic shock with severe biventricular dysfunction. So this patient has been taken into cath lab. Since femoral artery pulses are not palpable, we have gone through axillary artery, which is very much palpable because the coarctation is distal to the subclavian artery. So we have gone through the axillary artery. This is an angio showing a critical coarctation of aorta, as you can see here. And balloon is being inflated across the coarctation of aorta. And this is the final angio showing well open coarctation and very good supply to the descending portion of the aorta. So, follow up about this patient. This patient, the renal and liver parameters improved over a period of 7 days. Extubated on third day of procedure. He remained in hospital for 15 days because liver and renal kidney were very much hit. It took lot of time for recovery, but child eventually improved and has been discharged and has been on regular follow-up and he's been doing well. This is another case. 25-day-old male child came with bluish discoloration of body to OPD, was detected to have murmur by pediatrician and was referred for further evaluation. He has ejection systolic murmur grade 3, but SpO2 is very low. On echocardiography, what is important? Was detected to have critical valvular pulmonary stenosis. But in addition, the right ventricle was also hypoplastic. There was right ventricular dysfunction and foramen ovale was shunting completely right to left, and that was the reason patient was getting significantly desaturated. This patient had small PDA, but that PDA is not adequate to maintain the pulmonary blood flow, and that's why this patient was not maintaining saturation. In addition, there was severe tricuspid regurgitation because of critical valvular PS and hypertensive right ventricle. So this patient I was taken in cath lab. This is a balloon which is getting inflated across the pulmonary valve. That is how we do balloon pulmonary valvotomy. Pulmonary valve has been opened. This is an angio which shows the right ventricle and which is very hypoplastic. So when you have a hypoplastic right sided ventricle, this right ventricle will not accept enough blood from RA so that pulmonary blood flow is maintained. So in this case, we have done, in addition to balloon pulmonary valvotomy, we have put a stent across ductus arteriosus so that we are providing alternative blood flow, alternative blood supply to the pulmonary artery in addition to RV and pulmonary valve. So we have done balloon pulmonary valvotomy and we have put a stent across ductus arteriosus so that we have now dual supply to pulmonary artery so that this patient maintains saturation and comes out of severe cyanosis. This is another example. 20-day-old child came with decreased oral intake and altered sensorium, was detected to have high heart rate and referred immediately. This is an ECG where heart rate was in the range of around 200 per minute and no clear P wave has been detected. Patient was admitted. Immediately cubital venous access or whatever venous access you can take closer to the heart, you can take it. And adenosine injection was given in the dose of 0.1 mg per kg IV with rapid flush technique. And this is an ECG after adenosine with adenosine. This is a continuous ECG monitoring. As you can see, adenosine has been given somewhere here. And at this point, once adenosine reached the heart, this ECG has become normal and patient has gone into a sinus rhythm with normal heart rate. So that this again, this case example shows importance of having adenosine in NICU setup in your pharmacy store, so that you come across such patient. You can treat these patients in an efficient manner before transferring or referring this patient to the cardiac center. So what we do for giving adenosine, usually we take cubital venous access because it's a large bore access. And the rapid flush technique, what is rapid flush technique? We connect uh, 10 centimeter connector, and through a three-way, one side we connect adenosine injection and other side we connect a normal saline or a distilled water. We give injection adenosine. It can be, the dose is between 0.1 to 0.3 milligram per kg. We give adenosine and immediately we turn the three-way to the saline side, and we rapidly flush with the syringe and rapidly flush with the saline or a distilled water. And that this is why, because the adenosine reaches the heart rapidly, and adenosine has a very short half life, so it has to be very rapidly reaching the heart. And that is the response what we can see. The heart, once the adenosine reaches the heart, it breaks the circuit of tachycardia and converts this patient into a sinus rhythm. So again, this was a patient of short RP tachycardia. It was a neonate. Patient was started on propranolol 1 mg per kg twice daily. So what is important, that this patient can be managed in NICU. We have to give beta blocker. Usually this patient's outcome is very good. And by the age of 1 year, tachycardia subsides and we are able to wean off the patient from beta blocker therapy. So this is example of acquired neonatal cardiac emergency. It's a 4-day-old neonate, very low birth weight, male child, 32 weeks of gestation, 1.2 kilo child. Had a PICC line, was inserted from saphenous vein, but PICC line got fractured and was embolized to heart. And child was referred to UNM, our hospital, for further management because the PICC line has reached into the heart, causing a lot of ectopics to this patient. And if it is left behind, will develop thrombosis and can be a life-threatening. So this is in fluoro where you can see this is a PICC line. PICC line from saphenous vein has got fractured, has entered into right ventricle, and partly it is projecting into left pulmonary artery. So this PICC line is embolized and reached to the heart. This is an anteroposterior projection, and this is the lateral projection showing PICC line which is curled up into many folds, right ventricle into the left pulmonary artery. We immediately took this patient into the cath lab. We are taking this PICC line out with the help of various devices, and the PICC line has been completely taken out, as we can see in the fluoro image in an anteroposterior projection. So this was an acquired emergency which was created and has been published by us in cardiology in the Young Journal. So the key points, what is learning point from this presentation, that we should keep high index of clinical suspicion, because this critical congenital heart disease will not give much time. You should keep high suspicious and early diagnose, treat it in a timely manner and refer it in a timely manner so that we can salvage this patient. And early intervention is realistic in most forms of critical congenital heart disease. Most important thing, if we can salvage this critical congenital heart disease, they can have near normal life expectancy after its management. Thank you.
Thank you so much, Dr. Bhavik. It was a wonderful session.
Yeah.
From the pictures, we were able to understand all the pathologies very easily. And also at the end, you showed the cases and the live cath lab videos also were there, which was very helpful to understand how this kind of cases are managed. And the PICC line case was also very interesting. Thank you so much for the wonderful session. Unfortunately, we shall have to leave because of an emergency.
Okay.
If there are any questions, anyone can unmute.
Yeah, I would be happy to answer if you have any questions.
If there are any questions are there. So
Okay.
yeah, thank you for the
Yeah.
excellent.
Thank you, Dr. Kunal. It was wonderful to be in this platform.
Thank you so
And
much.
feel free for everyone to contact me in case of any need for cardiology. And good aspect, Gujarat is blessed with UN Mehta, I would say, because UN Mehta is providing completely free treatment till 18 years of age to all Gujarat patients, to all Ayushman card patients, and even SC and ST category kids of Pan India are being catered free of cost at this institute. And overall, I'm proud to say that we are doing a decent job in providing cardiology care in pediatric population.
We personally have referred many patients to you.
Yeah.
Um, uh,
Yes.
you might not remember, Dr.
No,
Kunal,
no.
yeah,
Yes.
Rakesh usually calls you. So
Yes. 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 Yes.
yeah, so we have personally referred you many patients, and we ourselves come to drop the patients because even transport is very difficult. So
Very,
we
very
should take
important.
care.
Transportation is very important.
Yeah, we should take also
Two
take.
learning points I would say that it's availability of prostaglandin and availability of adenosine actually is very critical when we are dealing with neonates with congenital heart disease.
Very true.
Yeah.
Thank you so much.
Okay.
Yeah, so
Thank you, everyone. It was nice to be at this platform. Uh, thank you,
yeah,
Dr. Kunal.
thank you.
Bye.
Shreya, thank you so much for the wonderful experience. You can end this session now.
Yes, sir. Thank you, sir. Thank you so much for